Patience is a virtue. All right. Well, I might start by acknowledging the traditional owners of the many lands on which we come to you from today. For those of us who are here in Kurulpuru and West End, we come to you from the lands of the Yagara and the Turrbal people, and I acknowledge their traditional custodianship of this land and pay my respects to their elders past and present. I also acknowledge the traditional custodians of the lands on which you all come to us from. And we reaffirm our commitment to a voice for Aboriginal and Torres Strait Islander peoples. Every QNMU meeting that we undertake also is undertaken under the banner of safety and respect. And what that means is that every person in this meeting has the right to feel safe and respected, and our meetings will be free from any forms of harassment, racism or discrimination. We ask that everyone acts in accordance with these values, and if there's any concerns, Dan, as the convener of the meeting, can assist you. You can send him a bit of a private message, but please, not that I anticipate tonight we'll have any of those problems. It's an awesome topic and one that I'm incredibly excited that we're able to bring to you. So QUT has done some amazing work in and around the nurse practitioner space. We have a very valued relationship with QUT as a research partner, and through that work, the work done on nurse practitioners, for which many of you contributed to the surveys and to the qualitative and the quantitative component, is actually going to result in your information being used to achieve improvements in your workplaces and to the broader profession. So without further ado, I would like to introduce the QUT team, being Carol, Oot and Mary. And Carol, I will hand over to you, and it's your time to shine.
Thank you. Thank you. Dan, did you want to say a word or?
No, I think that pretty much says it all. The only thing I would say, though, is that by way of background, this particular research project, the Grow Your Nurse Practitioner research, is part of a broader Grow Your Voice research project that we've been doing since the early 2000s, every 3 years, and a range of issues come out of each of those surveys. And in our 2020 survey, nurse practitioners was an area of research that we thought was a priority at that time. So this research comes from that. I really would commend this research to you. It's extremely interesting and very timely, given the workforce issues that we're experiencing across the board in health and aged care, more broadly, as well as in relation to nurse practitioners. And the final thing is that, just to let you all know, that we'll be recording this webinar tonight so that it's a resource for our members, for those who weren't able to make it tonight. So over to you, Carol. Thank you.
Thank you, Dan. Thank you both. Welcome to everybody to this webinar. We're very excited to be able to present the results of our nurse practitioner voice research, and we hope you will get as much out of the overview of the key outcomes that as we have got out of doing this research and doing the analysis. My name is Carol Windsor. I'm a professor in the School of Nursing QUT, and in a combined effort with my colleagues Mary Fennick, and Anne-Marie Haming, and with Dan Prentice from the QNMU, we undertook a Grow Your Nurse Practitioner Voice survey and a series of qualitative interviews or open interviews. This presentation presents some key outcomes from the two phases of the research, the survey and the individual interviews, that provide insight into the current context of NP practice in Queensland. We are most interested, of course, in following this presentation to get your input to this conversation, because you are the people who know much more about what's happening out there in the NP space than we do. I'd first just like to acknowledge the Turrbal and Yagara as the First Nation owners of the lands where QUT now stands. We pay respect to the elders, laws, customs and creation spirits. We recognise that these lands have always been places of teaching, research and learning. QUT acknowledges the important role Aboriginal and Torres Strait Islander people play within our community here at QUT. Dan mentioned some of the context, and I'll just go over it briefly. But the QNMU has supported and facilitated a triennial survey of issues related to QNMU members and their workplaces from 2001. And so 8 such surveys have been conducted. It's a remarkable longitudinal data set. From 2001 to 2016, the survey was titled Your Work, Your Time, Your Life, so people might remember that. And it gave insight into factors impacting on nursing and midwifery work in Queensland, satisfaction of nurses and midwives working in Queensland, career and professional development and wellbeing. In 2021, when the title changed to Grow Your Voice, that survey highlighted the various roles of MPs across Queensland. And as a result of the information that we received then, we conducted a Grow Your Nurse Practitioner Voice survey in 2021-22, which specifically explored the demographic and workforce characteristics that facilitated or otherwise the development of MP roles across sectors in Queensland. So we'd like to share some of the findings from the survey and from the analysis of interview data, but we also want to go beyond a mere description of those results to prompt you to question and consider alternative ways of viewing and addressing the MP problem. We call it the MP problem, and I'll explain why soon. MPs have been around for a long time, 20 plus years in Australia, and we continue or appear to continue to produce and reproduce a similar discourse. While some of this is important and perennial, for example, the limited access to Medicare rebatable items, there are broader processes in place that sustain the status quo. The importance of both the survey and interview analyses is that we bring 2 quite different lenses to the interpretations of research on MPs. And so we get insight into different dimensions of the whole area of interest around the MP role. The methodology for the quantitative survey recruitment, the survey was distributed via email to all QNMU NP members and to non-members via Queensland Health Team's platform, and email via the Australian College of Nurse Practitioners Register of MPs in Queensland. The time frame of the survey was 6 weeks, and there were 2 reminders. The sample, the Nursing and Midwifery Board of Australia MP numbers in Queensland at the time of the survey was 635, and the survey response rate was 215, or 36.3% of MPs, which was a magnificent response, and we thank you all. The study design was cross-sectional. It was an online survey via a secure research electronic capture, REDCap application. The first section of the survey addressed Queensland NP demographic information, including age, postcode, length of time endorsed as an MP, work status and work location, specialty work area, population of workplace team characteristics. NP's specialty areas were collated according to the Helm et al. MP meta-specialty groups that identified 6 broad NP clinical practice areas for the Australian context. That is ageing and palliative care, child and family health care, chronic and complex care, emergency and acute care, mental health care and primary health care. The second section of the survey focused on the work environment of the MP using the Meisner Nurse Practitioner Job Satisfaction Survey, which was modified for the Australian context and reduced from 44 to 34 questions. The survey is a validated and widely used tool and has been applied across a number of countries. Section 3 of the online survey used Lassinger's Conditions for Work Effectiveness Questionnaire 2, which measures the concept of structural empowerment, defined as the extent to which employees feel they have the capacity to mobilise information, resources and support to get things done within an organisation. There were also a few open-ended questions across the survey. A total of 182 NPs responded to the survey and engaged in the survey questions. The mean age in years was 49.46 years. So almost half of the respondents were younger than 50 years. And of course, the majority were female. 3 participants identified as of Aboriginal or Torres Strait Islander descent. And the MPs worked in a wide range of healthcare settings, with the majority in the hospital sector, the hospital acute sector, 52%, and only 6% in the aged care sector, which was a bit surprising for me anyway. MPs are working in a variety of specialty areas, with the highest proportion in ED, 29.4%. This slide shows the spread of MPs across the 6 areas: the acute hospital public, 50.3, acute hospital private, 1.7, domiciliary and community care, which is not surprising, general practice, 9.9, and probably the diverse sector, 8.3. Although 78% of this is the Meisner results of the survey, MPs' perception of knowledge and values related to their roles from the Meisner survey. Although 38% of respondents agreed and 13.3% strongly agreed with, I feel that my role as an MP is understood by my workplace management, a significant number either disagreed or were neutral to the statement. You can see the different measures there. And although there was a high level of agreement with the second statement, I feel that my workplace management sees value in my role as an MP. Only half that number, or a little bit more than half that number, went on to strongly agree that managers were knowledgeable of the role and motivated to use the role to its full scope. So there was quite a deal of agreement on my colleagues are knowledgeable about my role of MPs. MPs felt valued in the role in their workplace, in their role in the workplace, and perhaps there was slightly less agreement on, I feel that my workplace management is motivated to use the MP role to its full scope. A total of 163 participants completed the modified Meisner NP job satisfaction scale, ranging from very dissatisfied, score 1, to very satisfied, score 6. Overall, the scale indicated a minimally satisfied level of job satisfaction among NP participants, with challenges and autonomy and professional growth obtaining the lowest scores. There were significant differences in levels of job satisfaction in relation to employment status, specialty areas, population served, care settings, and to whom MPs answered managerially. And that's probably of no surprise. The lowest scoring factor was for professional growth related to support for continuing education and involvement in research and education. A total of 163 MPs answered questions in the CWEQ2 instrument, with scores from 1, no opportunities, to 5. This is the workplace instrument. There was with scores from 1, no opportunities, to 5, there were a lot of opportunities. 6 indicators: access to opportunity, access to resources, access to information, access to support, formal power and informal power were computed. The total CWEQ2 score was 19.625, where the highest possible score is 30, and a score between 14 and 22 considered as moderate levels of empowerment. The GE average score was 3.47, indicating that respondents did not perceive that they worked in an empowered work environment. So it's an interesting tension between the Meisner scale and this scale. Respondents were asked in the open-ended questions to comment on aspects of their MP role that constrained their practice. The questions were answered by 159 participants, and content analysis identified key concepts that reflected those constraints. And of course, the size of the text reflects the hierarchy of importance of the different concepts. So legislative restrictions, again, not surprising, was considered as the most significant constraint. Facilitators to MP practice. Participants were asked to comment on aspects of their MP role that they perceived would facilitate their practice. The questions were responded to, again, by 163 participants. And facilitating factors identified include autonomy, integration, expertise, practice scope, and recognition. Autonomy, again, was the largest text there, was considered the most significant concept as a facilitator to MP practice. So key findings from the quantitative analysis, what was important was autonomy, recognition, individual expertise, integration, conditions and governance. What was frustrating? Legislative restrictions and poor governance. So what became really quite obvious through the open-ended questions in the survey was not only the legislative restrictions, such as the lack of MBS, PBS item numbers, but also a lack of governance, which manifested in a lack of understanding and recognition of the MP role, a lack of support both professionally and physically, such as limited resources, and finally, the limited opportunities for MPs to innovate and to broaden their scope. Key points from the quantitative analysis. The findings from the survey data paint a picture of MPs and MP roles in Queensland. It's important to acknowledge, however, the limits of different forms of data and indeed in different forms of analysis. So the overview of the survey is just one dimension of the MP picture. If you like, it provides a bit of a snapshot, a bit of a description of what is going on in the MP space at the moment. What we sought to do with the analysis of the qualitative data was to move on from what is happening to address the how and why questions of the MP role. We had an overwhelming response to the invitation for individual interviews. In fact, 122 MPs indicated that they would agree to an interview. We couldn't do 122 interviews, and we conducted a total of 15 individual interviews via the Teams platform. Participants were selected on the grounds of that same stratification according to specialty category, private or public domains, and ABS classifications of major city, inner regional, outer regional, remote, and very remote. This method ensured a good cross-section of representation from all meta-specialties, regions, and locations. But thank you to everybody who indicated that they would like to, that they were willing indeed to be interviewed. The duration of the interviews was between 45 and 60 minutes, each interview. And of course, they were recorded and transcribed. We used what we call the Batchy framework, the work of Carol Batchy, for analysis of interview data. And I'll say a little bit about that in a moment. It's important to note that all interviewed MPs had vast experience over many years. All possessed qualifications in addition to an MP master's degree. All had embarked upon MP studies to expand their skill set so they could offer a broader range of services to clients and patients, etc. All were absolutely committed to their work. The starting point of the analysis was important. That is, it was important to understand that the MP interview responses were constructed within context. In other words, the interviews and the interviewees were situated in context that constructed the responses. So we sought to locate the interview comments within practices that generate to data. We recognise that data doesn't exist independently of the practices that produce them. We considered what was said in terms of what it produced rather than what it meant. We don't take data analysis as a reflection or a mirror on the truth. We're interested in what it produces in terms of process. We looked at the assumptions underlying the way that problems related to the MP role are represented, and we looked at how those problems are constructed at the level of practice rather than the broader political sphere. We looked also at the way that the problems could be conceptualised and interpreted differently, and this is what we hope will stimulate the conversation at the end of the webinar tonight. Carol Bakshi provided the critical lens through which the analysis was conducted. Carol Bakshi is a Canadian-Australian political scientist who is best known for the development of an analytic strategy to policy analysis. What's really appealing about Bakshi's approach is that it encourages us to take a step back and to look at how the problem of the MP has come to be represented in a particular way. What are the underlying assumptions of that representation, and what interests are being served, and what might happen if we challenge or disrupt that dominant discourse. So we've taken Bakshi's analytical lens and posed the questions that are outlined there. What is the problem? What assumptions underpin the representation of the problem? What is left unproblematic in this representation? And how and where has this representation of the problem been produced and disseminated? Can it be questioned, disrupted, and replaced? The following discussion addresses the key analytical issues produced from the analysis. It's worth noting up front that the concept of government was dominating, and it manifested in a number of ways. So taking Bakshi's first question, what is the MP problem? There was a lack of support in securing MP positions. Most frequently, the expectation was that MPs would create positions which involved the development of a business case, and often several times over. The lack of infrastructure support from clinical areas was not generally challenged because there was no option for MPs. The development of business case does feature in curricula in some MP tertiary courses, and that appears to be a positive step. But, you know, in a sense, the appearance of the business case in curricula just reinforces the expectation that defining an area of MP practice would be problematic, and that MPs would have to take individual responsibility for negotiating a role in existing services. MPs were also isolated in this transition into the workplace because often clinical managers were unsure where MPs should be placed, what their skills were, and to whom MPs should answer. The macro level within which the problem, as depicted here, has arisen is left unaddressed. So the concept of governance in the research context was largely used to indicate its absence. There were no structures to create solidarity among MPs at the state or local levels to address issues such as poor work conditions for MPs, the constraints of credentialing requirements, which we see as an example of surveillance of MPs reinterpreted as governance, factors important to develop and sustain an MP role, and perceptions of others of the MP role. Representations of the problem were underpinned by assumptions that were habitual, pervasive, and unchallenged. Medical hegemony is an obvious example, and there's the assumption that MPs are too expensive. The MPs at times reinforced these assumptions by comparing their standards of care to those at a medical registrar level. When addressing the perceived success of their roles, MPs cited relationships with medical practitioners or consultants as integral to that success. The MPs were lucky to have such relationships. That MPs were lucky to have such relationships was not questioned. The overriding assumption was that the current model of healthcare provision was appropriate and that MP roles should fit rather than challenge that model. The MPs did not, in the main, consider themselves politically active, but that such issues were the concern of others, leaving the MP to focus on patient care. So the clinical level was incredibly important. How has the representation of the problem come about? The system constructed individual MPs as responsible for the problem. The MPs were aware of the difficulties in working to the full scope of their positions and yet sought to justify this locally in terms of individual work roles and contexts. The MPs also, if implicitly, attributed such deficits to both a lack of governance and their own ineffective management of MP roles. In other words, the system was constructed in such a way that it ensured that any constraint on scope of practice was an individual MP responsibility, a view that MPs largely accepted. Where governance was addressed, there was a perceived absence of support in local sites and from broader institutions such as the Office of the Chief Nurse and Midwife. Where there was active governance, it was seen to be mostly driven by efficiency measures, such as the importance of nurse navigators, which MPs described as a curious distraction from the progression of their roles. Despite the above, MPs expressed gratitude to be in their current positions, even though they needed to continually sell themselves to others. Indeed, the language used by MPs often took the form of virtue talk and was therefore could be positioned in the context of the long history of nursing struggle, which suggests acquiescence. So virtue talk is talking everything up in a really positive way and talking about the characteristics of MPs. The participants spoke of being happy with their little corner of patient care and were okay about leaving the politics to others. Respondents also spoke of an expectation that they and other MPs should be grateful for their positions, which implied that they accepted a lack of standard expectations enjoyed by nursing peers. A way of demonstrating this gratitude was to be accommodating and flexible to many of the demands placed upon them. So what was left unproblematic in the problem representation? It appeared that what was left unproblematic was the continual discourse constantly being reproduced, or as one respondent described, as chewing the same bone over and over. The popular approach by researchers and others of reducing the MP role problem to lists of constraints and enablers provides a distorted view of the problem. We have two columns, the enablers, and we have lists of characteristics and constraints, and another list of characteristics which of course need to be fixed. Importantly, this representation of the problem is the way in which the problem is constructed as the real. The silence from all levels of nursing leadership and to a degree from MPs in challenging this representation and in not reconceptualising the problem more broadly only serves to confirm the problem, as Bacci would argue, as unfixable, the wicked and unfixable problem. We've accepted the status quo and we just need to work on what we identify as the characteristics that constrain MP work. So what effects are produced by the representation of the problem? A concern about being scrutinised permeated the responses of the MPs, although confident in their skills and abilities. And quite rightly, MPs were self-critical when speaking of the limitations to scope of MP practice. The MPs commented on a preoccupation with not exceeding their clinical scope for fear of reprisal. An ongoing sense of scrutiny through the credentialing process, in particular, reinforced the need to be cautious in practice, so not to invite reprisal at a local or legislative level. Here was a pervasive theme of quarantine, where respondents reported an avoidance of any overt political engagement, despite the political nature of the space within which they practiced. For example, service lines make it clear the expectation that MPs will financially justify their positions. This requirement reinforced uncertainty about future MP roles expressed by the respondents during MP studies and later on in efforts to establish or expand a service. The experience of being scrutinised and surveilled along with an often self-imposed quarantine created a sense of outsider status. At the practical level, the result of the representation of the problem was the loss of the potential benefits that the inclusion of an MP could contribute to client care in any team that provides care. The MPs were also vocal in pointing out the loss to management and to the profession of the significant leaderships that MPs had accumulated over many years of experience and education. This last point reflected an interesting tension between a concern about becoming more visible as leaders and regret that such skills were not valued. How and where has the representation of the problem been produced and reproduced? There was a perception of a significant disjuncture between university and clinical sectors and a desire for the tertiary sector to be a more active participant in the planning and implementation of NP roles. The divide between the tertiary and clinical sectors reproduced the status quo, according to respondents, that MPs had to complete their own business cases to secure employment. In an attempt to interpret the problem, quite simple reasons were posed, and the embedded broader structures that sustained the problem were not generally addressed. Some MPs did refer to isolated sources of support from nurses or medicine, and yet, as described by one respondent, this meant being completely dependent upon the person who was in the role, and that can swing either way. Such support was not systemic nor structural, and thus MP tenure was always at the behest of a local supporter. I want you to think about the disjunction between universities and clinical settings, and I think we take that as an obvious starting point. I wonder, thinking that through, whether there's such a disjuncture or whether there is some convergence between universities and clinical sectors about how the MP role is represented and perceived, and what the implications of that might be. Poor governance and strategising. The MP respondents pointed to the ad hoc and decentralised approach to the establishment of MP positions and a lack of planning for inclusion and succession of roles within services. The roles of MPs was perceived to be accountable to both medicine and nursing on clinical and professional matters, but often with a blurring of control at the expense of nursing. This duality subscribed to a recognition by all that medicine was the dominant paradigm within which positions and practices were shaped. The MPs were aware of what they perceived as the rhetoric of managers who talked of MPs as trailblazers and innovators, because such praise that perception was because such praises did not result in the provision of practical or professional support. And so there was here an obvious disjunction between the rhetoric of managers and the support that managers would bring to MPs. Other participants talked about strategies employed that were promoted as innovations to increase MP presence. An example, which we'll all be aware of so-called innovation, is the nurse navigator role, interpreted by some as a demonstration of poor understanding of MPs from the Office of Chief Nurse and Midwifery Officer. The nurse navigator role was introduced, was very generously funded, and overlooked MPs. or as one respondent described it, just left MPs hanging with no discussion of the role with respect to the MP. Some suggested that the introduction of nurse navigators was more realistically a political move to adopt a less expensive option than MPs, and that seems a very influential argument. Rather than being integral to service provision, MPs in this instance and in a whole lot of other instances were often viewed as an add-on. The MPs recounted how their suggestions for maximising roles in different contexts were shut down on the basis that they reflected too much change too soon. Against a background of poor governance in all its forms, there was a reliance on pre-existing and personal professional relationships for the MP role to succeed. Such relationships were not always available and added to a feeling of isolation and lack of solidarity between MPs who did not have such a smooth course. Loss of visibility and inclusivity. The invisibility of MP positions and of the work performed by MPs also meant a lack of acknowledgement of how a team approach could benefit clients and workplaces. Indeed, invisibility contributed to a lack of opportunity for innovation in clinical practice and to further career paths for MPs and succession planning for MP candidates. Also overlooked was the value of the role in terms of the relationships, connections and knowledge that MPs had developed over many years and the utilisation of those attributes to advocate access to healthcare for disparate groups. The intellectual capital and practical capital MPs bring to their roles is largely unrecognised or unacknowledged, I should say. Isolated from each other and excluded from the mainstream, even within the same institution, MPs adopted actions that perpetuated the situation. Such actions included a deliberate isolation by MPs in order to fly under the radar, which reflected a lack of MP leadership. Caution and fear of remand at a local and professional organisational level at times resulted in a reversion to a general nursing role. Interpreting the above as a lack of success of an MP role obscures the underlying conditions that contributed to the perceived failure of the role and obscures the underlying conditions that construct an MP role at times as a failure. Experiences within the credentialing process range from frustration and resentment to resolve and acknowledgement of an evil necessity and perceiving the process as a positive move. So there was the full spectrum of responses. Regardless of viewpoint, the concept of credentialing was foremost in responses. Some MPs viewed the credentialing requirement as a local verification process, while others perceive the process as exclusively a function of regulatory systems such as APRA and NMBA, and that endorsement as an MP by these bodies was sufficient. Practical problems with credentialing, such as lack of understanding of the MP role from credentialing committee members and inadequate principles to underpin the credentialing requirements, once again underlined the perception of poor governance. So some last words on the MP's situation as problematic. Viewing the MP situation as problematic is a positivist approach that arguably engenders a focus on what needs to be done to make it work, or let's fix it. This perspective obscures the economic and political interests and the context that have constructed MP practice. An important or remarkable case in point is the recurring impression in this research that there is a lack of nursing governance, a point which has not to date been reported as a problem. Further examples are credentialing and scope of practice. While it is acknowledged that the credentialing has since 2015 existed as a requirement for accreditation under the National Standards for Quality, Health and Safety, MPs remarkably appear as a unique group subjected to credentialing for core activities integral to their employment roles and for which they are already endorsed. Think about it. What is the representation of the problem here? Additionally, the Australian Nursing and Midwifery Federation has issued its own position statement that states that additional credentialing processes to determine professional scope of practice at the employer level duplicates the regulatory process, are overly restrictive and burdensome and reflect private credentialing, which is a really good statement. The MPs, while recognising the lack of governance in their sector, emphasised that such governance was applicable to nursing as a whole and that nurses at all levels of practice should be supported. Yet there was an overwhelming sense that for MPs, there was no one batting for them, and indeed they were ignored by nursing leaders who avoided regular engagement and dialogue with MPs across all settings. Also manifest in the interviews were the constraints on practice that limited access to MBS billing and PBS items for all MPs, irrespective of public or private location. The constraint was also always presented as a limitation on the services that the MP could provide, and really in terms of profit making or reimbursement. This is the first study of MPs working across all sectors in the state of Queensland and was commissioned by the Queensland Nurses and Midwives Union, which has demonstrated a commitment to understanding the context of NP practice and the broader political and structural factors that underpin the capacity of MPs to practice to their full scope. The outcomes generated from the analyses generally confirm the findings of the Grow Your Voice, from the qualitative analysis generally confirmed the findings of the Grow Your Voice Practitioner Voice Survey. Rather than present a repetition of the survey salient points, this phase the research did not produce a catalogue of participant comments. The interpretation focused on how the MP role has been constructed, understood, recognised, and communicated within the healthcare system, and moved beyond the identification of enablers and barriers that are perceived to promote or prevent MPs from providing optimal nursing care to the public. Importantly, although this analysis was specific to MPs, many of the issues raised are applicable to all nurses currently working in Queensland and elsewhere in Australia, and hopefully will serve to inform strategic work by the QNMU, in particular with respect to the MP workforce and its potential contribution to the future healthcare service provision in Queensland and Australia. We sincerely thank Queensland MPs for engaging with the survey, and also to those who accepted the offer to be involved in the interviews. We also give sincere thanks to the QNMU for facilitating and supporting the Grow Your Nurse Practitioner Voice 2022 research and their ongoing commitment to growing the voice of the MP. We thank you all. I just want to raise some, just here at the end before I close down this presentation, some potential discussion points, and these just reflect processes that are occurring now, and they are worth thinking about. I think they're worth thinking about in terms of the MP role and the implications for the MP role. For example, how do we explain the arguments for and the push for generic MP and generic RN roles? Do we consider this a fundamental attack on nursing? And you all, if you've listened to any sort of presentation over the last 12 months, and particularly since COVID, particularly post-COVID, there is, from nursing leaders, there's an enormous amount of emphasis on the concepts of flexibility, adaptation, and agility. I wonder what we find it remarkable, because the whole movement towards professionalisation and towards the construction of a career path or career trajectory for nurses with the MP at the pinnacle was grounded in the recognition of specialty roles. And here we see a very strong movement that's arguing for generic MP, generic RN roles. Specialties are considered too precious for nursing. How can we best explain arguments by clinical managers and academics for RN prescribing, and what are the implications for NPs? It's remarkable that the research comes from both the clinical area. The clinical areas, no doubt, are driven by economic considerations, but this call and this push is also coming from academics who are engaging in research. How can we explain this movement towards RN prescribing? How do we challenge assumptions about nurses that are not based in evidence? And most importantly, and we hope to hear from everyone here, how do we progress an alternative conversation in relation to NPs that is not reduced to a list of constraints, but that seriously engages with the underlying assumptions that have constructed the MP role and that continue to reproduce the MP role. So I thank you, and I'm going to close down the slides. I'll stop sharing. And what we would like now is to open up the floor to discussion from MPs and other people who are the audience here, and for you to consider what you think are the most important or the most significant issues in the NP space. And if somebody would like to put up your... Who would like to start off this discussion?
Can I?
Hello.
We did have a Penny put up a question during your while you were talking on
Right.
So Penny, if you're there, do you want to?
I've got it here. Yeah. So the question asked of the research participants about the committees the MP sits on at a local, national, state level. This, for me, has been invaluable to get MP practice and clinical recognition, clinical leadership recognised. We asked about, in the interviews, we asked about governance, and it appeared to us that governance coherent governance was a layer in MP practice that was absent, and that was evident in all the interviews that were conducted. We didn't ask specifically about local, state, nation, and state level, though we're very aware that there are bodies that are working really, really hard to provide governance for MPs. I guess what we became interested in was the lack of, rather than see MPs as separate from the nursing workforce as a whole, was the lack of governance across nursing that included MPs, that actually addressed any of the MP issues. That's what we saw as absent. But you, as MPs, would have a better idea of that than I would, for example.
To add to that, Karen, thank you for that response. I'm an MP up in North Queensland. I've been MP since 2008. Behind that question is with regards to being on things like the specialist guidelines committees in the state or of Australia, being on not only nursing committees but things like the financial and risk management boards and yes, whatever specialty somebody is wrapped up in, but to be at that level and show those committees that you are a clinical leader in your specialty and you know what you're talking about and everybody around the table knows what you're talking about and accepts you then as an MP, and that I think for me, has been able to promote my specialty in sexual health as a sexual health MP globally at a national level. And recently I was on the Ministers' Committee and I was the only prescriber for HIV medicines, for example. So these things, I think we can, as nurses, be a lot more forceful in pushing our barrow. And instead of being, I think we are our own enemy to a certain extent, that we don't push our barrows and push ourselves. And recently, just as an addition to that, I went to a meeting in Townsville and I was talking about my concerns about NP learning and NP students and NP candidates. And I would love for the QNU and QUT, and I studied through QUT years ago, to make it that a CN is not an NP candidate. You cannot come in on your days off or your long service leave to do this specialist training. And I agree with you, Carol, that this is a specialist position in clinical work. We have a career pathway to an NO8 position and a level 7 to an 8 position that is nowhere else. This is the highest we can go. No nurse is going to do an NP candidate position or an NP masters for funsies. This is hard work. And I don't think that we as QNU members are pushing this enough to our managers to say, this is not acceptable to have a level 6 position coming in to do their training on their days off and their long service leaves. If we can as a united body say, no, this is unacceptable behaviour on your behalf, Queensland Health, thank you very much. We will not be doing this anymore. This nurse has to be immersed into this position as a candidate position.
Yeah, absolutely. I agree with everything you've said. Can I ask you a question? Do you see the nurse practitioner workforce as integral to and included within the nursing workforce as a whole?
It is. Townsville has been very supportive over the years. I don't know about other places. I hear a mixed bag of responses from my other colleagues in sexual health around the state. But I think from the way that I have worked over the years, it has become an invaluable position. I
agree, absolutely.
Yeah, and even though I know I'm expensive, but I do bring in money in a case management perspective, case mix perspective. But I think the managers have been told that I'm worth 2 NPs when I retire. You know, that's the sort of role that I have developed over the many years with my scope of practice over 16 years of doing this job. So I think as beginning nurses in this field, I think hopefully nurse practitioners who are listening to me will be curious and push their boundaries and not be frightened to do this stuff. You've got to push it. And I've had to push it and I've had to question and I've had to be aggressive.
Thanks, Penny.
Really. Yeah.
Mary, Kelly, and then iPhone 2. I just want to say that hugely. Yep. Mary, sorry.
Carol, you go ahead.
I was just going to say that we agree with everything Penny has said, and some hugely supportive of nurse practitioners and recognise the great worth, the great skills and knowledge they bring to the healthcare system. But we've lost Mary. Kelly.
Oh, bugger.
Thanks,
Can you
Carol.
hear me?
You go, Mary, because your connection's bad.
Yeah.
Penny, I just wanted to point out to you that this research wasn't prescriptive. We didn't ask people direct questions, although there were surveys that had questions on them, but they were validated surveys. We didn't actually ask people specific questions in the qualitative interviews. And I'd like to point out to you that nobody actually spoke to the points that you've raised. So I guess that may just be reflective of the unique situation that you find yourself in. And if you broaden that out, it really exemplifies the diverse situations that a number of NPs are in, perhaps not nearly as satisfactory as yours. Yours may in fact be, an isolated position. So it's always, and I'm not having a go at you, Penny, I'm just saying it's always really important to keep that broader context there.
Kelly, thanks, Mary.
Thanks for that.
Thanks, Carol. For those who don't know me, I'm one of the QNMU professional officers who has the MP portfolio across the state. And I just wanted to add to Penny's comments. So in very recent days, as part of our election asks, we have made the point to what you're talking about, Penny, in that steering away from a focus on, I guess, a scholarship and university sort of candidacy program where people are coming in on days off and doing a lot of that lifting on their own. We are trying to make an ask around formalising those candidacy positions within the units in which people are working, where the specialty is either supported or needed, so that where we have seen project positions around this, we can start to leverage off that. So we, as the QNMU representing our MP members, are very cognizant of some of the variables in the way in which MP studies and candidacy work has been happening. And where in Queensland Health we have the MPC roles already in your wage classification, sorry. It's about maximising that so that we can ensure that people are able to immerse themselves within their own areas on paid time, if that helps with that.
iPhone 2, thanks, Kelly.
I think that might be me.
I think that might be you.
My name's Cassandra Stone, and I've been an MP endorsed since 2008, so in Mary's group.
Right.
So I finished with Queensland Health 2 years ago. I now work in primary health and still specialising in primary health as an MP CKD. So we were quite innovative at Logan Hospital when I started my position as NPC, and I was put into that role. And so, we were quite lucky when I started, and that certainly went by the wayside afterwards. Yeah. But the problem is once you get clinical, it's very hard to keep going off to meetings when you're trying to run clinics. Mm. And it doesn't matter what you say, anybody says, our medical team are still dictating on whether that role and model of care continues when, for example, I left the role. And that has got to stop. And I think it's got to be structured from the very beginning of putting your role together. It's got to be, yes, you'll discuss it with the doctor, complex patients or concerns, but they should not dictate how that position is run. And we do not have enough support from our executive nursing to tell them to, excuse the French, shove it up. Right. I think I was very disappointed after being in the role for 15, 16 years. Yeah. But I'm now working where I am completely independent. And I was really at Logan, but I'm completely independent and in a primary health doing chronic kidney disease only. And so early intervention, and when we're talking about generalists or specialists, I really do believe that just like your specialist medical team, I'm bringing that expertise to GPs so that they have a good understanding of how to look after that early chronic kidney disease patient. Generalists, I can see it with a GP. You've got to have a little bit of knowledge of everything, and sometimes it's not really at a level that is beneficial for the patient.
Thank you. Thanks so much. Jason, and then Julia.
Yep. Jason Harrison. I think most of you probably know me anyway. Probably a couple of things. One is in regards to the speciality stuff and obviously that statement about the generic NP stuff. Realistically, the thing that's really changed is the university's training of MPs, and it's become very generic and structured around the essential skills you need to be a nurse practitioner. But to apply, you still need to have an area of speciality to work in those areas. And I think the uniqueness about our role is that we're not siloed into health silos like our medical colleagues. They won't go outside their area of they won't go outside that area of specialty. They'll always refer on and stuff, where NPs are probably a little bit more flexible in regards to looking at the whole patient and where do I fit into that? And in some cases, how do I broaden my scope to support the patients that I'm seeing through my practice? But we also still stick to our specialty, but that we might broaden our scope to support our patients that we're seeing on a day-to-day basis. Because we need to do that, because especially where I work regionally, we don't have the same access to some of the services such as our metropolitan areas. The other thing is when we talk about governance, I know that I've been advocating on our ACMP and QNMU even, we've always advocated to have a director of nurse practitioners to provide that level of clinical governance. However, there are a few issues in that APRA have made it very difficult for an MP to hold a position like that, because you have to do total clinical and you have to do X amount of hours. Now, medical colleagues, they can become a manager or whatever, they still retain they're still known as a medical practitioner or area of specialty. Nurse practitioner won't, they will lose their endorsement if they don't practice X amount of hours. But, I know that when I've been at conferences and we've had the Office of the Chief Nurse for the Commonwealth speak on, I've always said that there needs to be a position in there for a nurse practitioner in that office to provide some strategic advice about nurse practitioners, but also workforce planning in regards to that, because you need an office that's comparable against our medical colleagues, because we're drowned out. And a lot of times we're not at the table. Though that's getting better now. They're really looking at the nursing workforce and making sure that there's a number of people from the nursing workforce there at tables when we're having health conversations. In regards to that, I think New South Wales has done it very well in the fact that they have transitional nurse practitioner positions and that people work in, and so they learn on the job as well as doing their study at the same time. Our nurse practitioner candidate positions would do that if we could get people from a workforce point of view to look at them as a valuable position in regards to making sure it goes through and that people are paid to do that, to learn the job, basically. And at the end of it, there is a job. So it comes things. The other thing is BPF, and from a Queensland Health point of view, there needs to be work done to recognise a nurse practitioner role, because it does generate activity. And in a lot of positions, that activity, actually, you're generating money for the health system. So you're not a costly nurse. And I've had that same sort of thing, that same rhetoric thrown at me that you're an expensive nurse. But I actually save you more in health dollars, my position, in regards to it than I actually think. But you always have to prove that. So it's always that justification. And look, I think our biggest threat at times is our own nursing colleagues. They don't understand the role, and especially at a higher level. And it's that constant education in regards to, and I suppose everybody gets frustrated about it. And I think as MPs, we sometimes are exhausted by the fact that we always have to justify our position, we educate people about our position and that. But look, it's 20 years. We're still in that
Yes.
pioneering phase. And I know people hate hearing that. It's taken 60 plus years in the US to get to where they are now.
Yeah,
And
yeah.
COVID was the biggest change factor for them to get more access to stuff. But yeah, we're fighting that medical model for healthcare, and it's going to be a long-term fight for all of us.
Yeah, thanks, Jason. Now, a very interesting point you make about the increasingly generic approach to NP education with universities. And because we've been talking with Mary and Dut and I have been talking in our team about the fact that we see a convergence between the interests of the clinical areas and the universities around the NPs, and the NPs are probably being somewhat disadvantaged by that convergence of interest, but haven't got any evidence, just observing. Good point. Julia.
Hi, thanks for this opportunity to talk. I guess I just wanted to talk to a couple of points that everyone's speaking about in regards to the nurse practitioner. I guess there's 2 points here. We've got private practice NPs that have their ways of funding, and then our nurse practitioners that work in the state system that sit on a band. And sometimes that can be a bit of a hindrance to us, I think, not necessarily about the money point, but where we sit. Historically, we look at authority usually by our level and band that we're seen by. And as the clinical experts, our scope, our authorised legislation authority as dietitians, treating clinicians that can do the whole full circle of care, we sit in a band where we sometimes have our leaders above us that don't understand our practice, don't understand our scope because it's not their scope of practice. And so sometimes we're not sitting at the clinical tables that they're sitting at and making clinical decisions that can show and put forward our expertise. I think Penny's really right. There's a huge number of nurse practitioners that sit on national clinical guidelines, and the more we sit on that from a treating clinician nursing perspective is where we're going to have more input in evidence and creating things from that point of view. I think the branding is really important, and the understanding in terms of from our other health colleagues about have an understanding about nurse practitioners as treating clinicians. We saw our training is a little bit different and backwards. I'm doing the scope of practice for the state at the moment, which is a conjunct with QNMU and OCNO and Office of Chief Nurse about looking at scope of practice for all nurses. But within an NP space, we sort of do our generalist training, then we do our expert training, and then our master's qualifications really gives us that authorization to be that diagnostician, to be that authorizing treated clinician, where our medical colleagues seem to get a lot of authority as soon as they become a doctor in terms of legislation. They're recognized, and then they do their specialist training. So it's trying to articulate that across is what's really important, is how we can hopefully move things forward.
Yeah, interesting that you talk about the work that you're doing around scope of practice. I'll be watching scope of practice, the evolution of scope of practice in nursing for maybe 10 more years. And what I observe, Julia, and I don't know whether you would agree, is that concept of scope of practice is generally a strategy used by management to change the labour force and the nursing labour force in some way, rather than it being a definition of what a particular nursing professional would be doing.
In the nursing scope, from even our other health colleagues, they want a list of things. They want task orientated. They want from the generalist nursing. But the more you in-depth it and understand that scope is education, competency and authorization, and that's fluid and that can change against all our entitled registrations, being an enrolled nurse, a registered nurse or a nurse practitioner. And I think in the nurse practitioner space, there's a lot more optimal scope we can change. There's a lot of authorization that needs to be addressed in legislation, because just of higher historical moments no one's ever thought about, without the mentioning of a nurse practitioner there, why they don't have authority. So everywhere you mention a doctor, it means that they're usually a first year or a second year doctor has the authorization to do that. Now, they may not have the clinical competency or the education in that space, but they have the authorisation. And so that's the lens we need to start by looking at when we're looking at legislation and policy, is that nurse practitioner needs to be there. Now, that doesn't mean every nurse practitioner on day one is going to be able to do or have the education and competency, but they're given the right authorisation and recognition that at some point some nurse practitioner will be able to deliver that care in that space. And I think that's the way we need to move forward.
No, I think
We're
the
an
legislation would be.
Yeah, we're an endorsement at the moment against a registered nurses registration, but the more I think and the more I look, I feel like we need to be a registration of a nurse practitioner. That has to be a registered nurse, but that's a whole bigger thing. But really our scope of practice is so significantly different in authorisation in legislation to our registered nurse colleagues. It really needs to be seen as that different, and as soon as we can break that away, it might actually show our potential for moving forward. But the training stuff is really important. I think that from a state government point of view, we train our medical colleagues from, we get accreditation for every college they deem the hospitals being accredited to be able to do that. They invest in training from our registrars to other levels of the consultants, and there is no investment in the treating clinician of the nurse. And so that is something that has to change. Every model that's being put up is putting nurse practitioners in it, which is exciting and amazing. But when they can't fill them because they're not investing in training, is a real downfall of the state government.
Thanks, Julia.
I've got to go. Thanks.
Okay, see you. Melanie and then Dan. Hi, Melanie.
For people who don't know me, I'm the president of the Australian College of Nurse Practitioners, and I'm a private primary healthcare nurse practitioner. So Jason and Julia covered a lot of my points, but a few that I want to add to that. I think the study was probably conducted, was it 2001, 2002 is sort of when you did it?
2021, 22.
So I think we've actually progressed. I would like to think we have progressed since that time that study would have been conducted. And one of the things that I haven't heard mentioned is that we are the first workforce in Australia to actually get our own workforce plan. So I think we need to think that we have got a national workforce plan for nurse practitioners, and a lot of our barriers are addressed in here. And that I think that we are slowly starting to turn from a federal government perspective, and that this document is definitely worth a read if you haven't read it. We need to start, you know, some of the things that are significant barriers are in there.
Okay. Thanks, Melanie. Dan, we're heading towards 7 o'clock, but
the other key point
sorry, Melanie, sorry.
Is that as a college, adding on from Julia, we've put in for the third time our pre-budget submission for a college for us to do a professional framework.
Yeah.
We can do credentialing as a college. So
right.
That's the third time that we've put in to do that.
Right.
So there is significant barriers around us as a college doing it. So
indeed.
Yeah. So I think
that's interesting. Dan.
Thanks, Carol. Look, I'm not a nurse practitioner, but extremely interested in the space. I'd really like to thank Carol and the team for, I guess, producing research that fosters debate, and I think that's probably the most important thing. I'll get my 2 cents worth in and just follow on for a couple of themes that, again, I think identifies as the range of structural issues that need to be dealt with here. And perhaps they are being dealt with slowly, but I think need to be considered in any of this debate. The issue around candidate positions is just simply one symptom of a broader issue within nursing workforce. And say in the public sector, the absence or lack of candidate positions is simply reflected in other issues like the absence of associate NUM positions or the absence or relative absence of enrolled nurse advanced skills positions. So we're seeing a broader landscape where a lot of capacity in, say, the public sector award and enterprise agreements isn't being utilised fully. So what you're seeing as nurse practitioners really is just one aspect of a broader absence of decision-making around nursing positions and how that would enhance service delivery. The other thing I'd like you to think about is that the vast majority of nurses work clinically, but where is that? But it's not reflected in the capacity of the clinical stream to offer reward and recognition. You've got to go outside of that. So essentially what we're seeing is people moving out of the clinical stream to advance beyond, say, nurse practitioner level, up into a management position where there is reward and recognition. So I'd pose to you, it's my view, my personal view, but what we need to do is build a reward and recognition side of things to the clinical aspects of nursing, where the vast majority sit, to, I guess, move the argument along. Because
a perennial problem, Dan, a perennial problem.
So we've got this bizarre situation where the vast majority of nurses max out at really effectively grade 7 in the public sector, because the number of nurse practitioners is relatively small compared to that. But and I think we need to learn some lessons from medicine here, in the sense that they value staying in the clinical stream, and that's where the reward and recognition is. So there's some interesting things there that I'd like you to think about. And I suspect that unless we get that recognition of a clinical stream, then we're forever going to have this problem of people who've moved out of the clinical stream making decisions for the majority of people who remain in the clinical context. So, and I would also pose the question is that, should NP be really the only advanced practitioner role in a clinic, in a nursing clinical stream? I would argue that probably not, but that's just me. And I like the idea too, that the idea of the regulatory side of things was brought up, because at the moment we have this, I guess it would be fair to say that from a regulatory environment, it seems to be very much focused on a generalist nurse who's, that terrible phrase, job ready. So there's a lot of, I think, debate that you probably need to have within the nurse practitioner scheme of things around some of those structural issues and how they might impede or advance what it is that you want to do as nurse practitioners as a group. So that's just my 6 cents worth. I'm happy to hop up on that soapbox anytime.
Thank you, Dan. We know.
But yeah, something to think about.
Yeah. Ut? You're muted. Oh.
Yeah, thank you, Carol. And first of all, I would like to thank you all of you who are nurse practitioners. I am just registered nurse. I am an academic. I am not a nurse practitioner, but I'm very interested in nurse practitioner space, and I have been very fortunate to be able to be involved in this work with Carol and Mary. So just I would like to offer some of my own view in terms of knowing this outcome of the research, as well as observing what's challenging, but also things that nurse practitioners have been done widely to the community. So first of all, authorizations. I would like to think that once you being endorsed, that way you should be authorized. So we need to make those happen. We don't need to get that authorizations, even why we need to prove or justify ourselves for that. Credentialing, I would like to have that process to be rethink. For example, as a registered nurse, I only need to submit very simple application to renew my registrations. Why nurse practitioner have to go the whole process, which I'm not sure 100% in details, but I would say that I know in terms of process. Why do you have to do that? Because you already graduated, you already endorsed.
Yep.
In terms of money's aspect, I really like the comment from Jason's. You talk about, apart from caring or providing specialties, with the area you really extremely expertise on, you also provide other supporting for clients or the public. How can we justify for that in terms of money? I think if you just go into the business case, we might not be able to provide that justification, and then we would get the answer back, oh, you are very expensive. But in actual fact, we not just about deliver the money or benefit to whatever profit or something like that, but we go beyond that money-wise aspect in providing a much better care for the public. And I would like to think that need a really systematic approach, and that not only relies on nurse practitioners, but just, you know, some sense of the thinking that I, as an observer, I just like to put it out there.
Good observation, Sid. Good observation.
Thank you.
We could have just time for one more if somebody wants to make a contribution, or we're sitting on 657. Did you want to say anything, Mary? No.
Yes, I do. Yes, I do.
Oh, you're frozen though. Mount Isa frozen. Yeah. I think we'll stop here then, because Mary's absolutely frozen.
I'm sorry.
That's all right. It's not your problem. And we'll talk again. But I want to thank everybody who's joined this webinar and engaged with us tonight. Change doesn't occur quickly. I think, Jason, you made that point, 60 years. But and we don't want to wait 60 years. But just having these conversations and disrupting where we can the status quo, and talking and attempting to reframe the issues in some way is part of that process of bringing about change. It won't bring about immediate change, but it is a really significant and important part of that change process. So thank you all for participating. I truly appreciate it. It was lovely to see you here and to listen to you.
Yep. Now, Carol, I'd like to reiterate that. I'd like to thank you, Carol, Mary and Oot, for the hard work that you've put in on this. This is groundbreaking research. This hasn't been done in the Australian context. And I think that's the importance of this, is that it's important to shine a light on some of the issues and look at things from different angles. And this provides a perspective that really hasn't been talked about terribly much before. And I think that's the importance of this. So thank you, everyone. Thank you to the QUT team, the QNMU team who are here tonight, and everybody else, all those nurse practitioners out there that have logged in tonight. I'd like to thank you very much. And
indeed,
it's been a wonderful opportunity to, I think, get to talking about these things is the most important bit. And out of that comes action. So talk about it. In the college, in the branch, we need your feedback.
Thank you. Thanks, Dan. And thank you all.